Uh, Dear students and super specialty aspirants, this DocTutorials module on SS NEET 2023 recall papers, we have been doing as each and every super specialty consultant has been doing their part of the various recall questions. I'll be covering the plastic surgery questions. I am Dr. Vijay, Professor of Plastic Surgery, and there were very few questions this time. Let us start with the first question. Yeah. Usually, cleft lip and palate is a very important topic. Most of the questions will be on what is the time of operation for the various procedures in cleft lip and palate. When is a cleft lip operated? Around 3 months. Cleft palate operated around 9 months. BPI around 2.5 years. Alveolar bone grafting around 7 to 9 years. And orthodontic procedures after 13 to 15 years, and finally rhinoplasty after achieving puberty. This time the question was on embryology. So what are the sutures which lead to cleft lip formation? I couldn't collect the various answers, but the answer is frontonasal sutures. Let us go through the embryology of cleft lip and palate, which is very important. So during the third week of gestation, the mesenchyme from the first and the second pharyngeal arches lead to the formation of the neural crest cells. So these neural crest cells then form few bulges like the frontonasal prominence, paired maxillary prominence, and the mandibular prominence. So here you can sort of see it: frontonasal prominence, okay, paired maxillary prominence, and a mandibular prominence. So all these things finally differentiate into skeletal muscle, connective tissue, bone, cartilage, which all compromise the structures of the face. So the first and the second pharyngeal arches leading to the neural crest cells and forming the structures such as frontonasal prominence, maxillary prominence, and the mandibular prominence is the first step which takes place at the third week of the gestation. At the end of the fourth week, nasal placodes, which are nothing but the nasal pits, which develop for the formation of the nostrils, okay, they invaginate to form these nasal placodes, then invaginate to form the nasal pits. As they invaginate to form the nasal pits. Sorry, let me clear this up. Okay, as the nasal placodes invaginate to form the nasal pits, what happens is the frontonasal prominence forms a medial nasal and a lateral nasal prominence. So this is the medial nasal prominence, this is the lateral nasal prominence. So basically, the frontonasal prominence divides into medial and the lateral nasal prominence due to the development of the nasal placode. Here itself, I would like to tell the medial nasal prominence leads to the formation of the structures such as the nasal tip, columella, philtrum, and the premaxilla. So let us take a diagram like this. Okay. So this is the nose, the columella, the philtrum, the lip. So just see what all the medial nasal prominence gives. This is a very important question. The medial nasal prominence gives the nasal tip, the columella, which is this part from the nasal tip, which is attached to the lip here, the philtrum here, and premaxilla. So this premaxilla is nothing but the premaxilla itself is defined as a bony premaxilla and soft tissue premaxilla. Anterior to the anterior palate, the hard palate is there, and it gives rise to an alveolar arch, and alveolar arch has upper four incisors and the central part of the upper lip. All these constitute the premaxilla. So the medial nasal prominence gives rise to these structures. The lateral nasal prominence just gives rise to the nasal ala. So this is a very important point. Okay, if a question is asked, where is the lateral, where is the nasal, how is the nasal ala formed? It is lateral nasal prominence. Okay. So during the fifth and the sixth week, Now, from the frontonasal prominence, the maxillary prominence starts pushing the medial prominence to the midline. So both the medial prominence comes to the midline, and so here is the medial. Once the medial prominences comes to the midline, they obliterate and fuse by 7 to 8 weeks here. Okay, the cleft between the medial nasal prominence and the maxillary prominence, mind you, not the lateral nasal prominence. The cleft between the medial nasal prominence and the lateral nasal prominence basically uh, fuses to form the upper lip. 1 second. Fuses to form the upper lip. The fused medial nasal prominences forms the philtrum. The fused medial nasal prominences form the philtrum of the upper lip here, whereas the lateral nasal prominences form the lateral lip of the upper lip. Okay, and here you can see the mandibular prominence, which is nothing but the jaw. Okay, so the mandibular prominence, as the name suggests, gives the rise to the mandible. So here the point is the failure of fusion between the medial nasal prominence and the maxillary prominence leads to the formation of a cleft lip, and that was the question. And this happens usually the failure of the fusion, or the fusion happens at the 5th to the 6th week, and the failure of the fusion, which is usually occurs due to the problem in the 5th to the 6th week, leads to the formation of the cleft lip. So to complete it, we will also say how the palate regenerates, or the palate forms embryogenesis of the palate. Okay, so the paired medial growth of the maxillary prominence gives rise to lateral palatine shells. The lateral palatine shells from the lateral part moves like this and fuses in the center. Okay, at 7th week, it fuses in the midline and to the nasal septum in the midline. Okay, fusion is usually anterior to the posterior direction. So this, when there is a fusion of the maxillary prominence, they fuse to form the intermaxillary segment. So here is the intermaxillary segment. This intermaxillary segment has a labial component and also has a bony component. The labial component forms the philtrum, and the bony component forms the upper four incisors, the anterior palate, and put together this is called as the what is that premaxilla. Okay, so the intermaxillary segment is actually the premaxilla, and the maxilla actually forms the intermaxillary segment. Whereas the lateral palatine shells fuse posterior to the incisive foramen, and at 10 weeks it leads to the fusion of the hard palate, and soft palate fusion takes place by about 12 weeks. So failure of this fusion of the lateral palatine shells at 10 to 12th week of embryogenesis leads to the problem of cleft palate. Mind you, cleft palate embryogenesis is very different from the cleft lip embryogenesis. So these are the key points of it. Again, the next question was about from the pediatric plastic surgery. The question was on Treacher Collins syndrome. Treacher Collins syndrome was also called as the mandibulofacial dysostosis. So they just put up regarding Treacher Collins syndrome, what is true? It is a congenital craniofacial malformation that involves the middle and the lower thirds of the face. It affects both bony structures and soft tissues. It is transmitted by an autosomal dominant gene of variable penetrance, and it is also called as a combination of the craniofacial cleft 6, 7, 8. Okay, Treacher Collins syndrome is considered to be a presence of the craniofacial cleft 6, 7, and 8 put together, and the salient features of the Treacher Collins syndrome are zygomatic hypoplasia, which is usually found in the 6 cleft, vertical pterygomaxillary deficiency, or basically this is a maxillary deficiency with a steep occlusal plane. Usually the occlusal plane is horizontal, whereas in the case of Treacher Collins syndrome, it has been found there is a vertical occlusal plane, and also this maxillary deficit is a feature of the 7 craniofacial cleft. Inferior and the lateral descent of the lateral canthus. The lateral canthus becomes inferior descent. Again, it is a feature of a 7 cleft, and the absence of zygomatic arch, especially the inferior and the lateral orbit. This has been found to be a feature of the 8 cleft. So, zygoma hypoplasia, 6 cleft, absence of lateral zygomatic arch, which is seen in the 8 cleft, and absence of the reduced pterygomaxillary height with a steep occlusal plane and the lateral descent, which is a feature of 7, put together is called as a Treacher Collins syndrome. Now, any features of Treacher Collins syndrome with upper limb abnormalities, with upper limb congenital anomalies is called as a Nager syndrome. This is the extra point. Okay, so any case of Treacher Collins syndrome with any case of Treacher Collins syndrome with limb anomalies is called as a Nager syndrome. Treacher Collins syndrome itself is a combination of 6, 7, 8 cleft, and Treacher Collins syndrome plus limb anomalies is called as a Nager syndrome, right? So let us, those were the salient features of the Treacher Collins syndrome. Sometimes you might be given a picture like this, and you might be given the other features of Treacher Collins syndrome are also. So I'm going to explain about the various other features of Treacher Collins syndrome also. In the eyelids, you can see the anti-mongoloid slant, that is the obliquity of the palpebral fissures is inferior. There is coloboma of lower eyelids. Coloboma means there will be a defect in the eyelid like this. Okay. So if this is the eyelid, there will be a defect like this. So this is called as the coloboma eyelid. Okay. So usually this is how a coloboma eyelid will be there. Okay. So there can be also coloboma iris, but here there will be coloboma of the eyelids, especially the lower eyelids. Okay, there will be dystropia of the lateral canthi. There is a destruction of the lateral canthi. The antimangulate slanting or the sloping will be there. Okay, short palpebral fissures. The width of the palpebral fissures will be short. There will be absence of eyelashes. There will be notching of the eyebrow and the upper eyelid. So these are all the eyelid features. In the orbit, if you see, in the orbit, the various features are the lateral wall of the orbit is absent. Because the lateral wall of the orbit is absent, the zygomatic arch projection is also absent. Okay, there is a hypoplastic or absent zygomatic arch. The narrow maxilla. See, this is the area of the maxilla which is narrow, under projected, and there is a high narrow palate which is not seen here. The mandible, as you can see, is hypoplastic. Vertical occlusal plane. Usually, the occlusal plane is horizontal like this, but here you can see a vertical occlusal plane. There is a class 3 occlusion with an anterior open bite. In class 2 occlusion, there will be a maxillary hypoplasia, whereas in class 3 occlusion, there will be a long and retruded chin with a protruding maxilla. The nose will be protruded, broad, flaring will be there, and other features like microtia can be there, absence of the external auditory canal, abnormalities of the middle ear, and thereby hearing loss can be there. Macrostomia. Here you can see like a joker, the lip is there. This is usually seen in the 7th cleft. And also because of the palatal problems, there can be velopharyngeal insufficiency leading to speech problem. So uh, these are the extensive features of Treacher Collins syndrome. The other question was on trauma in orbital fracture, all except or causes of late enophthalmos in orbital fracture. Enophthalmos means the eyeball goes inside and it is usually examined with a Hertel's exophthalmometer. You can see the vector of the eyeball is more inward. Okay, that can happen in case of orbital fracture. The various options given were orbital floor collapse, muscle atrophy, reduction in edema, orbital fat necrosis. But mind you, the question which they have asked is all are the causes of late enophthalmos except, okay. So, mechanical or physically, when the orbital floor goes down, the eye sinks in, and therefore acutely only orbital floor collapse causes the enophthalmos. Whereas even when the orbital floor doesn't go down, but if there is an extensive trauma to the muscles of the orbit, or when there is orbital fat necrosis due to extensive trauma, later on they can develop late enophthalmos. That is why my answer is orbital floor collapse. Orbital floor collapse causes an acute enophthalmos in orbital fracture, whereas muscle atrophy, reduction in edema, and orbital fat necrosis causes it's a late cause of enophthalmos. So orbital floor fractures can occur as isolated fracture, or it can occur associated with the zygomatic or the maxillary fracture. If it is occurring as an isolated, it is called as a pure blowout fracture. Okay. If you see orbit, okay, in the orbit there is a medial wall, lateral wall, inferior wall, and the superior wall. The most common wall to be fractured is the orbital floor. Then is the medial wall. And then comes the lateral wall or the roof. So whenever an orbit fractures, the fracture can cause a blow-in fracture or a blow-out fracture. In blow-out, see, this is a blowout. The fracture segment goes down and the total volume of the orbit increases. This is called as a blowout fracture. You can see compared to this volume is high and therefore it causes enophthalmos. Whereas blow-in fracture is the fracture segment goes into the orbit and therefore decreases the volume of the orbit and therefore the eye protrudes. So there is exophthalmos. So again, blowout fracture will cause enophthalmos. Blow-in fracture will cause exophthalmos. So what are the clinical features? You can see because when there is a fracture, the inferior muscles, there are two muscles, the inferior rectus, which causes the inferior downward gaze, and the inferior oblique muscles. Both can get trapped into the fissure fracture. Okay, and therefore they both will prevent the upward gaze. Also, if the orbital fat and the septae is entrapped, that also will cause the prevention of the upward gaze. Okay, so there can be either trapping of the muscles or trapping of the orbital fat and the septae. These are the mechanical features. Here you can see this is the teardrop sign in the coronal CT section. This is the orbit. You can see the inferior rectus muscle and the inferior oblique muscle here. Okay, and you can see the haziness here. So it looks like a teardrop, and this is called as a teardrop sign. Such a thing is orbital inferior rectus entrapment is much more common in children. Okay, and when in children, it causes entrapment of the inferior rectus muscle. It causes intense vagal stimulation, and it is called as oculocardiac reflex. The oculocardiac reflex consists of bradycardia, nausea, and syncope, out of which this nausea and vomiting is very heavy. Clinically, I have seen if a kid comes and tells I was hit by a ball and tells continuously and if the kid is telling nausea and vomiting, do not think of a head injury, think of a blowout fracture. And the beauty is sometimes it is called as a white blowout because there won't even be some amount of conjunctival hemorrhage. At least you can suspect fracture when there is a conjunctival hemorrhage, but there won't even be any conjunctival hemorrhage. Okay, and the orbital floor might appear very small, minimally displaced. At least when the orbital floor is totally displaced, there will be enough thalamus, but there won't be entrapment. But if the orbital floor is just a fissure fracture, because of increase in volume, it will just open, entrap the muscle and close. This impingement of the muscle will create intense parasympathetic stimuli, which will cause to bradycardia, nausea, and syncope. Okay, and also it will cause hypoglobus and enophthalmos. So this is about the orbital floor fracture, and the indications are mainly for orbital floor. It has to be done immediately, either within 6 hours. If you don't do immediately within 6 hours, the entrapped muscle will go for necrosis because the ischemia withstanding capacity of the small muscles are very less, and within 6 hours it goes for ischemic necrosis. It becomes fibrous, and later on, even if you correct the orbital floor later on, okay, the enophthalmos will never get corrected. So that is why within 6 hours we have to operate the orbital floor, causing persistent entrapment and enophthalmos. If you reduce, but you reduce at a later time, still the diplopia will persist because now the muscle is not physically entrapped, but it is paralytic due to ischemia. So the diplopia can be either due to entrapment or it can be due to paralysis and fibrous conversion. Repair of the orbital floor is by a titanium plates. You can see here, these are called as the orbital rim plates or the titanium plates. And orbital floor fractures are usually treated with the orbital floor titanium mesh plates or even calvarial bone grafts or sometimes inner cortical grafts of the iliac crest or the pelvis. Okay, so we can either go for an autologous grafting or implant grafting. The other question is flap thrombosis. What is the next step? It's not heparin or saline, it is mechanical thrombectomy. When they are talking about flap thrombosis, what they are talking about is a free flap case. So, in a free flap, in which case the flap is taken along with its blood vessel and a recipient vessel is found and an anastomosis is done. Since a vascular anastomosis is done, the chances of thrombosis is very high. Thrombosis in free flap surgeries can be divided as primary thrombosis or secondary thrombosis. primary thrombosis means there is a problem in the technique, either closed sutures, far away sutures, taking a bite wall, or taking a wide sutures, etc. Whereas secondary thrombosis means initially the technique is fine, initially the flap survives, but due to hematoma, due to kinking, due to edema compressing on the vessels, there will be secondary thrombosis. Whatever it is, when there is a flap compromise, if there is a arterial compromise, the flap will be cold, pale in color, and will suggest a faster re-exploration. And if the flap has a venous congestion, the flap might bleed faster, will be much warmer than the surrounding area, and there can be venous congestion and extensive edema. So in free flap, if there is a thrombosis, we have to evacuate and redo the anastomosis. And therefore, the salvage can be done only by doing a revision in the operation theatre. Whereas in the case of venous insufficiency of a flap, uh, in fact, it is the more common compared to the arterial insufficiency because of the low pressure in the veins and extrinsic, it is amenable to compression due to extrinsic pressure. Various things can be done. First of all, you can release the inserting of the sutures. Therefore, the kink and the tension is less. If not, you can even serially prick the flap. Thereby, the venous congestion is relieved and therefore further flow is improved. Sometimes de-epithelializing, removing only the epithelial portion of the flap, and therefore the dermal plexus is exposed, leading to continuous bleeding, also can salvage the flap. In case of the replant, sometimes we remove the nail plate and scratch the nail bed and also keep a heparin soaked gauze piece, and thereby we ourselves do a sort of phlebotomy and thereby salvage the flap. Sometimes the same thing can be done by medicinal leeches, and some other time you cannulate and periodically you put an angio catheter and periodically drain the flap. Okay, so this is provided the venous insufficiency is due to a non-technical problem. If it's a technical problem, here also you have to go and revise. If it's a non-technical problem, all these steps can be followed one by one, and therefore the flap can be salvaged. The other question was, which is the flap with the least complication rate in breast reconstruction? Deep inferior epigastric perforated flap, or transverse rectus abdominis pedicled flap, or muscle sparing tram flap. Okay. So what is the various in DAEP? It is a perforated flap. Therefore, the inferior epigastric vessel is chased. The muscle is totally spared. In tram flap, the muscle is not spared at all. So when the muscle is taken along with the flap, you have to keep a mesh and close the abdomen. In muscle sparing tram, you don't chase the perforator. You take only a small chunk of muscle. Thereby, the complete rectus abdominis is not violated. But here too, they have been found that later on incisional hernias are coming. And therefore, I will say DAEP, if done in a good institute with the technical expertise, deep inferior epigastric perforator flap has the least complication rate when compared to the tram. Here, when I mean complication, it's not only about the final output, it is also about what happens to the donor side. And that is why my choice is DAEP flap. In breast reconstruction, the commonly done procedures are tissue expander. It can be either autologous procedure or an implant-based procedure. In autologous procedures can be tissue pedicled flap, that is a tram flap, or it can be free flap, such as a deep inferior epigastric artery flap, perforator flap. Whereas in a implant-based reconstruction, here the various options are tissue expander placement with a later exchange for implant. Here means, first of all, the mastectomy is done. Now the skin is just there and the bare chest is there. First, you keep an expander. You expand, you expand the tissue covering over the tissue expander. Then you remove the expander and put a implant. Immediate permanent implant placement. This is possible. Sometimes if primarily during mastectomy, we do the case. Here, after doing a mastectomy, we just place the implant and put a LD flap simply because there is no skin at all. You cannot push and pull the skin. Or here, that's what latissimus dorsi with implant. Okay. So if in case of implant reconstruction, it is in later reconstruction, you can either place the implant in the subcutaneous pocket or in the submuscular pocket. Submuscular pocket is much better because there is a full muscle coverage. And in the inferior pole, if there is no muscle coverage, you can keep a bioprosthetic material like a bovine dermis. And in subcutaneous pocketing, visible rippling of the implant and capsular contracture are the more common complications. This is a picture showing submuscular pocketing, and it is always seen that inferior lateral part of the implant is exposed, and we land up keeping an bioprosthetic material like an bovine dermis. In autologous, like as previously told, the gold standard is a transverse rectus abdominis muscle pedicle flap previously, and these are the various zones according to the Moon and Taylor classification. It is a musculocutaneous flap. It is a type 2, it is a type 3 muscle with the two good blood supplies, superior epigastric and inferior epigastric. If tram flap is done as a pedicled flap, it is done as a superior epigastric based flap. But if it's done as a free flap, it can be taken as a inferior, deep inferior epigastric perforated flap or a deep inferior epigastric artery muscle sparing flap. Free flaps have less partial necrosis and fat necrosis than compared to the pedicle flaps. And also, while doing a free flaps, the epigastric bulge is reduced because while rotating the flap, the ugly rectus muscle bulges near the epigastric area. And the commonly used recipient vessels for a free flap are thoracodorsal vessels and internal mammary artery and vein. So, in muscle sparing tram, only the muscle surrounding the perforating muscle is taken. This is the muscle sparing tram. In DAEP flap, only the perforator vessel is taken here. And in SIEP, sometimes the superficial epigastric artery, which we usually cut during a hernia surgery, itself can supply. That is the best thing. Absolutely no complications will be there. So other flaps are gluteal based flap. Superior gluteal artery perforated flaps, inferior gluteal artery perforated flaps. It is called the S gap and I gap flaps. Tug flap, transverse upper gracilis flaps, which is ideal for women who don't want to take the abdominal tissue. And the tug flap is based on the ascending branch of the medial circumflex femoral artery. Basically, it is a supply to the gracilis muscle, and it basically takes a upper inner medialmost aspect of the thigh. Oncoplastic, we all know, is rearrangement of the breast tissue after lumpectomy. Can be done immediately or after 1 to 2 weeks, but it is usually done before radiation. So when you say, I'm going to read out the various complications. In implant-based reconstruction, capsular contracture is the most common complication. In latissimus dorsi muscle flap cover, the back seroma is a very known complication. Fat necrosis occurs in 50% of the pedicle flaps. The hernia and epigastric bulge occurs in tram flap, that is pedicle flaps. Partial loss is more common in pedicle flaps. Total flap, all these complications are not there, but if technically solid team is not there, it can go for a total flap loss. Chemotherapy has a little effect on the outcome, and radiation therapy has an impact on reconstruction. Immediate reconstruction is followed by radiation, has complication rates of 87%. Nipple areola reconstruction is usually done 2 to 3 months after the adjuvant therapy, using the nipple local flap techniques. Areola is usually reconstructed by a full thickness graft from the groin or by the medical tattooing. And usually after the nipple only the areola is created 4 to 6 weeks after the nipple. Okay. In SSG, what is true? Low primary contracture has low metabolic demand, and low primary contracture is due to the high metabolic demand. Let us see what is the primary contraction, what is the secondary contraction. We all would have seen a harvesting in SSG. When a split skin grafting is taken and kept on the table, immediately if you find the amount of graft which you have taken and what is found in the table is always small. So that immediate contraction from the body to the table is called as a primary contraction. It is not contracture, it is contraction. This contraction is due to the immediate recoil of the elastin in the dermis. Okay, whereas the secondary contracture is due to a late contracture that happens after 6 months due to the myofibroblast activity. It has been found that the thicker the graft, the more is the primary contracture. And we all know the metabolic demand is usually high for a thick graft. And therefore, for that question, more the metabolic demand, more is the primary contracture. Whereas in a thinner graft, the metabolic demand is less. Therefore, the primary contracture is less, but the degree of the secondary contracture is more. So with this, I'm finishing the SS NEET revision of plastic surgery questions. Thank you.
Am I audible? Hello.
Yes, sir, you are audible.
Is my screen visible?
No, sir.
Have you made me the host?
Yes, sir, we have done.
And now is it being visible?
Screen is visible, sir. Our video is not visible.
If I try to on my video, my screen is going. That's why I'm not able to do it. Okay, my video is not a matter, no? The screen is visible. Is it now visible?
Yes, sir, visible, sir. Good to start, sir.
Okay, can I go ahead? The participants are
So YouTube live, sir.
okay. Okay, shall we go? Shall we start?
Sir, screen PPT, please.
Yeah, now.
Good to go, sir.
Yeah. Welcome, students, for one another session in DocTutorials. This time we are going to discuss the previous year's questions, those which has been asked. I went through all those questions, and I could see that all those questions uh, are a somewhat modified form of our previous discussions, be it colon, be it rectum, be it esophagus. All have been discussed in our regular classes, and I hope you'll find this session very easy if you have gone through the previous discussions, which was taken series wise, both Saveston as well as Bailey. I also found one interesting thing in that they have asked even some questions from which have been direct lines from Shuttlefoot. But that constitutes only very minor part of your questions. So without much wasting time, now we'll go to the questions one by one. I have sorted it as per the chapters. The first question. So this was a patient. Who was suffering from regurgitation, dysphagia, heartburn, and they had given an image of an endoscopy, which was showing Barrett's and Corey Barrett's Corey GRD Corey Eosinophilic esophagitis. This was the sort of questions the students came to us and gave it. On further analysis, this is a typical um, picture, endoscopy picture, which was showing eosinophilic esophagitis. And the question which was asked was, what was the best test to diagnose? And the options given were A, biopsy, B, 24 hours pH monitoring, C, manometry, D, impedance. Now, coming to the explanation. So, eosinophilic esophagitis. So, this condition might occur in children as well as in adults. It might occur alone or as a manifestation of eosinophilic gastroenteritis. Now, just a minute. Yeah. Yeah. So it might occur alone or as a manifestation of eosinophilic gastroenteritis. So it might be a part of an allergic phenomenon or it might have no cause. It may be a part of idiopathic mechanism. More than 50% of the patients suffering from eosinophilic esophagitis have history of allergy. And the most common presenting symptom is dysphagia. Now, if you see the endoscopic picture. This is one such kind of picture which describes all those findings. So you will have rings in it, the furrows in it, and the mucosa is typically labeled as the crepe paper mucosa. That is, it is as thin as a crepe paper. That is what we describe as it as a narrow friable esophagus. So on the other endoscopic findings which can be found in eosinophilic esophagitis are uh, deep ulcers, and on coalescence of these deep ulcers, they form even stricture in the proximal esophagus. And these are the findings I've already discussed: the rings present in mucosa, the mucosal rings, the furrows, and the mucosa, which is typically described as a crepe paper mucosa. And so to go to the diagnosis, we can have the diagnosis established by endoscopic biopsy. So in endoscopic biopsy, if you take a biopsy with a UGA guided, you will describe what is called as 15 or more eosinophils per high power field. And that is the typical diagnosis which is established by endoscopic biopsy. And that is the investigation of choice to prove it is the eosinophilic esophagitis. And the treatment for eosinophilic esophagitis is mainly our goal is to reduce the 15 or more eosinophils per high power field to less than 5 eosinophils per high power field, thereby rendering the patient less symptomatic and to improve in his general condition. So what all we can do? So this as a part of being allergic phenomenon, you have the diet eliminated which is sometimes the source of this eosinophilic esophagitis, and you can resort to steroids. What Bailey says is topical steroids such as budesonide, fluticasone, or all those steroids which are preferred in the short term, and systemic steroids are less preferred. But Shackelford says even systemic steroids can be given to those patients. And a novel mechanism to counteract this eosinophilic esophagitis is the immunotherapy against interleukin 5. You know all that. Interleukin 5 is the interleukin which is responsible for recruitment of the eosinophils. So when you do target the immunotherapy against interleukin 5, you're going to get rid of all those eosinophilic esophagitis. Sometimes, especially in adults, where there are findings such as deep ulcers and further scarring, you have the options of endoscopic dilatation as well to prevent to prevent further stricture formation or to get rid of the stricture which has been already formed by the coalescence of these deep ulcers, which we said already that deep ulcers form strictures in proximal esophagus. So endoscopic dilatation can be used, and that can be used only when all the above therapies, the medical management the avoidance of allergic factors and all those has been tried and has failed already. Then you have the option of endoscopic dilatation. So coming back to the question, so we have a patient who has the typical symptoms of regurgitation, dysphagia, and heartburn, and you have got an endoscopic findings which already has shows rings and furrows. So the diagnosis is straightforward. It is eosinophilic esophagitis, and the investigation of choice is biopsy. So the first question is done, and second is there was a history of an elderly male who underwent a transthoracic esophagectomy with POD2 Riles tube showing coffee-colored aspirate, and the patient complained of chest pain. On examination, his vitals were in the borderline of 80 to 60 millimeter mercury with tachycardia for around pulse rate 120 per minute, which was suggesting an unstable condition. On lab investigation showed high counts. And what is the next done investigation was what was asked. Now, since it is POD2, all these parameters suggest that it is a leak. It is a leak, and it is a leak. Sometimes it even hints of an a necrosis. So they have asked clearly what is the next investigation done now. We have seen all this while discussing our regular classes. So how do you diagnose leak if it's a cervical leak? If you've done an anastomosis in the cervical region, that you do after hybrid McEwan's and all that. So cervical leak will present within 5 to 10 days. It will be present with fever, drainage, and wound erythema. So the second type of anastomosis where what you do is after an Ivor Lewis surgery, what you do in the thorax, it is the intrathoracic anastomosis, and the leak after intrathoracic region, intrathoracic anastomosis is always less apparent. It's less apparent, and the patient will have an unexplained low-grade fever, tachycardia, and leukocytosis. Sometimes patients will have conduit necrosis, and that will present within 48 to 72 hours, and 48 to 72 hours, and the patient will have catastrophic sepsis. So the most obvious sign of esophageal leak is having bilious output in surgical drains. So if you see the lab investigations, there will be increase in CRP, there will be increase in total counts, and the albumin, there will be decrease in albumin. All these predicts the major complications. To be specific, the best investigation or the preferred investigation is CT. But if they ask what is the next investigation of choice, it is the contrast swallow. So you can give a water soluble contrast, and you can do an upper J contrast study and determine the nature of the leak, the site of the leak, and the type of leaks. If it is a grade 1 leak, it is going to be clinically silent, and it is to be detected on protein imaging. Now, to be specific about intrathoracic leak, intrathoracic leak might present with sepsis or without sepsis. If there is no sepsis and the leak is a contained leak, then you can go for an percutaneous drainage. But if there are features of sepsis and the patient is hemodynamically stable, then you can take the patient after all the investigations which are required to prove that it is leak, and you can go and take him in OT, and I can give a thorough lavage and wash and drainage in OT, keep larger drains, and you can try even to refashion the anastomosis. But if you try to refashion the anastomosis, always there is a chance of recurrent leak around 25%. Now, coming to the patient who is hemodynamically unstable with sepsis, then you have to think of conduit necrosis. Conduit necrosis. So if it is a conduit necrosis, there is no other option. Go in for a VATS or do a thoracotomy, then try to dismantle the anastomosis, keep it as an end esophagostomy, do a venting gastrostomy, and provide HJ for a source of nutrition, and then come out. Now, if there is a minor breakdown, in a patient who is hemodynamically stable, and the circumference of the breakdown is less than 30%, then you can always place it in a covered stems, self-expanding metal stents, with or without percutaneous drainage of the collection. Now, there are some contraindications of stenting in such leak, like if there is non-viable conduit, if there is leak within 2 centimeter of the cricopharyngeus muscle, or when there is severe angulation of conduit, or if there is esophagojejunal conduit. So all these conditions, you should not do stenting. There is also a role of endoluminal vacuum therapy when there are collections just outside the esophagus, and there is a larger perforation. Then you can always go and do an endoluminal vacuum therapy, deployed in a vacuum and connected to the vacuum device outside, and keep it at a pressure of minus 125 millimeter mercury. Then you have always got the option of curing the leak. And so here in our patient, he is a POD2 patient where the patient is hemodynamically unstable, and it might be a conduit necrosis leading to conduit necrosis. Thereby leading to an intrathoracic leak. Then the next investigation or next action would be going in for a VATS or a thoracotomy. So to be specific, as per me, if they ask with such scenarios, that too in POD2 and hemodynamically unstable, and the next step, then next investigation, you have to go in for a surgical exploration. But if the patient is hemodynamically stable, then if they ask, then you can go in for a best investigation, or next investigation is an upper GA contrast study. If they have given CT and upper GA contrast study, upper GA contrast study forms the next source of investigation, whereas CT is the preferred source of investigation. So as per me, the condition here described is conduit necrosis in POD2, and the patients are unstable, and the vitals are the patient is hemodynamically unstable with features of sepsis with increased counts. The next step would be a surgical exploration. Okay. Now, we'll see this question a little later. Now, the next question, the fluid of choice in gastric outlet obstruction. How do you treat a patient with gastric outlet obstruction? To answer this question, you need to know what is the electrolyte abnormality in gastric outlet obstruction. So it is gastric outlet obstruction. It's always considered malignant until proven otherwise. Sometimes it might be benign, and the most common cause of gastric outlet obstruction is gastric cancer. And it is always a pyloric stenosis, what is being said, but it is a misnomer, and the stenosis is commonly in D1. Now, what happens is when the patient has gastric outlet obstruction, he tries to vomit HCl. That is H plus and chloride minus. With this, what happens is the chloride is getting lost. What happens that is acid is getting lost. If there is acid getting lost, the condition what forms inside the body is hypochloremic alkalosis. Yes, yeah. Now, what happens when there is hypochloremic alkalosis? The kidney tries to counteract the loss of HCl by decreasing the acid, that is decreasing the excretion of chloride, and increases the bicarbonate excretion. When to maintain this, the increased bicarbonate excretion is always along done with sodium. So there is increased excretion of bicarbonate and sodium. In while doing so, that with time the patient will become progressively hyponatremic. This is the second abnormality. I already said the patient is having hypochloremic alkalosis. Now he is becoming hyponatremic and becomes dehydrated because of excessive sodium excretion. Now the body tries to conserve sodium excretion by retaining sodium and then excreting potassium and hydrogen. So it tries to excrete H plus and K plus in place of Na plus. So while doing so, H plus is getting excreted in urine. So you see the mechanism. Already the acid was getting out of the body through vomitus. Acid again H plus again acid is getting excreted in the urine, which is the same. So it should have been reversed. Now that to prevent acid through vomitus, kidney tried to do some mechanism, but ultimately it is excreting acid only. So paradoxically, acidic is the urine, and along K plus is also excreted. So it is hypokalemia. To remember it in a nutshell, it is hypochloremia, hyponatremia, hypokalemia. Alkalosis is the condition of the body with urine becoming paradoxically acidic. So that is what is called as hypochloremic, hypokalemic, hyponatremic alkalosis with paradoxical aciduria. And with all this, with alkalosis, the body also tries to decrease ionized calcium. In alkalosis, so the patient will tend to develop tetany. And this is what are all the electrolyte abnormalities which the patient observes in gastric outlet obstruction. Now, how to manage this patient? So the best management would be to rehydrate the patient, because the patient is already dehydrated. The patient should be rehydrated with IV isotonic saline, and also to replace the potassium which is being lost through the kidneys. So replace the body with IV isotonic saline with potassium supplementation, and replacing the sodium chloride and water allows the kidney to correct the acid base abnormality. So following rehydration, it becomes obvious that the patient is also anemic. So the hemoglobin will also be high, spuriously high on presentation. So this is how you restore the electrolyte abnormality. To restore sodium chloride, you have to give what is called as the normal saline with KCl supplementation. So the answer would be normal saline with KCl supplementation. But always you have to, in such cases, treat the original cause. That is, take the biopsy around the pylorus, exclude malignancy, and endoscopic dilatation of the gastric outlet may be effective in less severe cases, may not be successful in long-term cases, but you need to do a surgery for benign condition, or if it is a malignant, you have to go in for a resectional surgery and treat it that way. Now, coming to the next part, it is the question is what are the nodes removed in D2 gastrectomy? So we have already discussed this enough in our original class discussion. So what is D2? So D2 is, so D1 is perigastric lymph nodes. That is, 1 is the right cardia, 2 is the left cardia, 3 is the lesser curvature, and the 4 is the 4SA is the short gastric, 4SB is the left gastroepiploic, 4D is the right gastroepiploic, and 5 is the suprapyloric, 6 is the infrapyloric. This 1 to 6 forms the perigastric lymph nodes and forms the D1 lymphadenectomy, part of the D1 lymphadenectomy, while D2 is along the major arterial trunks. That is, 7 is along the left gastric artery, 8 is along the common hepatic artery, 8A is along the anterior part of common hepatic artery, 9 is the celiac trunk. You could see this. 10 is along the splenic hilum. 11 is along the splenic artery. And you have got 11P, 11D. Sorry. Is my screen visible now? 11P is proximal part of the splenic vessel. D is the distal part of the splenic vessel. And 12 is along the hepatoduodenal ligament. 12A is along the artery. And 12B is 12B is along the bile duct. And 12C is along the cystic duct. And you have got these part of the lymph nodes which constitutes the T2 lymphadenectomy. Now, this is clear. The answer to this question is nodes removed in D2 gastrectomy is D2 is along the splenic artery. Now, what you must be knowing is what are the lymph nodes removed in D2 subtotal gastrectomy as well as total gastrectomy. So in D2 subtotal gastrectomy, so always in D2 it is D1 plus all those lymph nodes along the arterial trunk. Now in D2, if it is a subtotal gastrectomy, you need not remove lymph nodes 2, that is along the left cardia, and 4SA, that is the short gastric, because you leave the part of the stomach which is relying on short gastric vessel, so you need not go and remove the short gastric. 10 is along the splenic hilum, you need not touch the splenic hilum, and 11D is along the distal nodes, distal along the splenic artery. So 2, 4SA, 10, and D. These part, while conserving the subtotal part of the stomach, to not be touched while doing a subtotal gastrectomy. Again, in D2 total gastrectomy, you have all the nodes 1 to 6 along with 7, 8A, 9, 11, and 12A. But again, you in all our D2 gastrectomy, we need not do splenectomy as a part of the routine procedure that was given by the Dutch trial. Now that the recommendation is very clear, need not remove the spleen. So we need not remove 10th lymph node. That is station number 10. So 10 is not removed. So if you just remember this, in subtotal, we don't remove the nodes along the left cardia, the short gastrics, the splenic, the one along the distal splenic vessels, and one along the hilum. Then that forms the T2 subtotal gastrectomy. Otherwise, all other nodes are moved in subtotal gastrectomy. And total gastrectomy, we remove everything except station number 10 now. And this is what described in this diagram. Now, what are the other nodes in CS stomach which are of importance is 13 is the retropancreatic, 14 is the superior mesenteric vessels, vein is 14V, artery is superior mesenteric artery, 15 is middle colic, 16 is along the para-aortic. So along the para-aortic, 16 is distant anatomical locations. We have got the 16AL, that is along the hiatus, and 16 A2B1 is para-aortic middle, and 16B2 is para-aortic caudal. So this is the option A, that is along the para-aortic forms the 16 lymph nodes. But the question asked is D2 gastrectomy, so it is along the splenic artery. And coming to the next question, which of the following gene is involved in familial gastric carcinoma? So we have already described in detail about the hereditary causes of gastric carcinoma. So there are other syndromes along with what syndrome is specific to the stomach, that is called as hereditary diffuse gastric cancer. Hereditary diffuse gastric cancer. Saviston says there is a risk of 60 to 70% lifetime risk of CS stomach, and Shackelford says there is 80% lifetime risk of CS stomach in hereditary diffuse gastric cancer, and the gene mutation which is implicated in hereditary diffuse gastric cancer is CDH1 gene mutation. that is E-cadherin gene mutation, and this is most commonly associated with lobular carcinoma of the breast. The other gene is PAL2 gene mutation, and the lifetime risk is 67% in male and 80% in females. And on screening upper GI endoscopy, they trade the protocol is that the prophylactic gastrectomy is recommended in around 18 to 40 years. Sabiston 21 edition says at around 30 years, and endoscopy is recommended every 6 monthly or yearly. This is the hereditary diffuse gastric cancer, which has got a 80% lifetime risk of CA stomach. Apart from this, we have got the other syndromes which forms the hereditary causes of gastric cancer. One is the Lynch syndrome, which is autosomal dominant syndrome, and all are autosomal dominant. That is Lynch, juvenile polyposis, Peutz-Jeghers, and FAB. The Lynch, the mutations responsible are MLH1, MSH2, MSH6, and PMS2. The lifetime risk is 1 to 13%. And the intestinal variant stomach cancer is observed in Lynch syndrome. And screening, you have to do endoscopy till the jejunum. And in juvenile polyposis syndrome, the gene mutation implicated is SMAD4, and the lifetime risk is 21%. And the polyps are present yearly. If the polyps are present, then yearly screening endoscopy is recommended. If the polyps are not present, then 2 to 3 yearly screening is recommended. In Peutz-Jeghers syndrome, which is an autosomal dominant syndrome implicated in the causation of CA stomach, the gene mutation is STK11, 29% lifetime risk of CA stomach occurs in mid-teenage. The same strategy of screening, that is yearly when polyps are present, and 2 to 3 years when polyps are absent. FAP, APC gene mutation is present, and the lifetime risk is 1% in fundus, which is forms a non-adenomatous polyp, and duodenal and periampullary are more common. And 25 to 30 years is the age group, and you have to do a side-viewing endoscopy till duodenum. Other syndrome which is implicated in CS stomach is the Lee-Frommeny syndrome, which is the P53 tumor suppressor gene being implicated. So what are the genetic alterations associated with gastric adenocarcinoma? It is the c-MET overexpression, K-SAM oncogene, and CRB2 are the proto-oncogenes which are responsible for gastric adenocarcinoma. So the answer for this is which of the following gene is involved in familial gastric carcinoma? It is CDH1 gene, and the lifetime risk is around 60 to 80%. And the prophylactic gastrectomy is recommended in around 18 to 40 years. 18 to 40 years. Now, what are the features suggesting this finishes the stomach and esophagus part? Now coming to the colon and rectum, features suggestive of Crohn's disease over ulcerative colitis or all except and or all. One options are granuloma, full thickness, fistula, all of the above. So when you see ulcerative colitis and Crohn's, you must understand that Crohn's is a transmural disease, whereas ulcerative colitis is mainly restricted to the mucosa. So the mucosa, so there will be transmural involvement, lymphoid aggregates, and granuloma, which are present in Crohn's colitis. So you will have a thickened wall with a thickened mesentery and the serosal fat trapping with segmental disease involvement in Crohn's colitis. All these will be absent in ulcerative colitis. That is the thickening of the wall, mesentery, fat trapping, segmental disease, transmural involvement, no granulomas in ulcerative colitis. All these are strong suggestive features of Crohn's colitis. Clinically, the patient will have bleeding per rectum in ulcerative colitis and diarrhea. And sometimes patients, due to the transmural involvement in Crohn's, will go in for obstruction. And remember that the Crohn's colitis, the involvement of anal and perianal disease is more so frequent in Crohn's, and the risk of cancer in Crohn's is more compared to ulcerative colitis. While this is different in different sources, in Sabiston clearly says the malignancy is more common in Crohn's colitis, and always Crohn's will have small bowel disease involvement. So to remember, the involvement of small bowel, the involvement of anal, the involvement of perianal region are more predicting in terms of Crohn's disease. And if you do a colonoscopic in this patients, patients will have aphthous ulcers, deep longitudinal ulcers with cobblestoning of the mucosa, which are all characteristic of Crohn's. And the distribution will be discontinuous, unlike in ulcerative colitis, where there is a continuous distribution of all this disease process. And the disease will be friable, and the involvement of rectum is almost always present in ulcerative colitis. pseudo polyps are characteristics of both. What are the complications in both of this? The involvement of anal and perianal region in Crohn's leads to fistulas, postoperative recurrence, cholelithiasis and nephrolithiasis are also common in Crohn's, which are absent in ulcerative colitis. And These are the distinguishing features for ulcerative colitis and Crohn's diseases. So, granuloma, full thickness involvement, fistula are all strong suggestive features of Crohn's disease over ulcerative colitis, and these are all absent in ulcerative colitis. So, answer is all of the above. Coming to the next, which of the following is the treatment of choice of Mr. X having 4 episodes of bloody stools with fever, with tachycardia? On colonoscopic examination, features of inflammation are present, and biopsy taken shows features suggestive of dysplasia. Now, you have to analyze this condition in 2 forms. One is the parameters which are being given. The parameters given are the number of stools, the presence of fever, the presence of tachycardia, and features of inflammation on colonoscopy. Biopsy is the second part which you have to analyze. Now, coming to the first part, so this is the criteria which you have to apply for this patient and for all ulcerative colitis patient. This is called the true love and which criteria. The true love and which criteria has components like the frequency of passage of stools, the bloody stools, fever, tachycardia, anemia, ESR, or even CRP might be taken into account. Coming to the frequency of the passage of stools, it is 4 times or less in mild, 6 times or more in severe. Any times between these two, that is 4 to 6, forms moderate. If bloody stools might be absent or present in mild, it might be present in severe. Fever, tachycardia, anemia are all absent in mild, and fever, tachycardia, anemia, all these are present in severe. Now, if ESR is normal, it is mild. ESR is more, or CRP is more, then it is called severe. So you have seen all this. If all the 6 criteria, that is absent fever, absent tachycardia, absent anemia, plus or minus bloody stools, normal ESR, 4 times or less frequency of defecation, if all the 6 criteria are satisfied, the disease is said to be mild. And if any criteria, 1 and 2, and either of the systemic symptoms like 3 and 4, and at least 4 out of the 6 are satisfied, then it is sick, then it is severe. As per the question, the patient is having a severe acute ulcerative colitis. This forms a one part of the question. And apart from this, on colonoscopic biopsy, they have said that it is showing dysplasia. Now, what does this American Cancer Society guidelines recommend? You have to do surveillance colonoscopy for all such patients, all the proven ulcerative colitis patients by biopsy. The routine surveillance colonoscopy is every 1 to 2 years, beginning 8 years after the onset of pancolitis and 12 to 15 years after the onset of left-sided colitis. So traditionally, 10 random biopsy specimens were recommended. However, it has been suggested that at least 30 specimens can be obtained. What does the implication of dysplasia here means? So, if there is a low grade dysplasia, the risk of carcinoma implicated is 10%. If there is a high grade dysplasia, then it is 30 to 40%. If it is dysplasia associated with mass or lesion, what we used to call, that is DALM, DALM, dysplasia associated mass or lesion, the risk of carcinoma is around 50%. In both high grade dysplasia and DAM, you have to have this confirmed with the second pathologist. And multiple areas of low grade dysplasia, high grade dysplasia might also be present in the same patient. So any dysplasia, be it low, be it high, be it dysplasia associated with a mass or a lesion, be it multiple areas with scattered low grade and high grade, always consider the patient for proctocolectomy. Proctocolectomy should be done in dysplasia. So these forms the indications of surgery in ulcerative colitis. Intractability is the most common indication. Intractability is that if the patient has got severe disease, you can start with steroids, IV steroids. The patient is not able to respond to your steroids. then you can give rescue therapy. Even if the patient is not able to give respond to rescue therapy, then you have to go in for surgery. So that is the most common indication for surgery in ulcerative colitis. Dysplasia, carcinoma is the second most common indication. And third is if the patient at any point of the time develops fulminant colitis or toxic megacolon. For toxic megacolon, we know the Jalan's criteria, that is any three should be present. The heart rate greater than 100, total counts greater than 12,000, temperature greater than 38 degrees Celsius, the diameter of the transverse colon more than 5, or some books may say 5.5 centimeter, then you have to go in for surgery. Yeah. If the patient is having fulminant colitis, toxic megacolon, sometimes in malnutrition or growth retardation in pediatric patients and adolescent patients, and dysplasia, if it is multiple, like high grade, low grade, or any dysplasia, consideration should be given for surgery, that is proctocolectomy. So our patient, if you analyze both forms, that is, he's having acute severe ulcerative colitis also, and on colonoscopic biopsy, he's having dysplasia also. All the more, both are making us to think and take the patient for surgery. So option here are surgery, steroids, aminosalicylates, or observe. So I would go with surgery with strong indications such as acute severe ulcerative colitis and dysplasia being the two most common indications here in this patient to take up surgery for this patient. So never forget True and Ritz criteria, the American Cancer Society guidelines of screening colonoscopy, and the ratio of the risk of carcinoma for these patients, and the indications for surgery for ulcerative colitis in these patients. Now, there was one such question: which of the following is true as per Montreal's criteria for inflammatory bowel disease as per A2, B2, L2? So this is a state question, what I was discussing. There are one or two questions taken from Shackelford, and Shackelford clearly describes the classification of Montreal of inflammatory bowel disease. So for Crohn's disease, and it is separate for Crohn's disease, it's separate for ulcerative colitis. Now coming to Crohn's disease, the parameters will be A, B, and L. A is age at diagnosis. B is behavior of the disease. L is location of the disease. And as per A, you have got A1, A2, A3. A1 is 16 years or younger. A2 is 17 to 40 years. A3 is more than 40 years. And B is behavior of the disease. B1, B2, B3. B1 is non-stricturing, non-penetrating. B2 is stricturing disease. B3 is penetrating disease. And L is the location. It is L1, L2, L3, L4. L1 is terminal ileum. L2 is colon. L3 is ileum and colon. L4 is upper GI. And L4 is upper GI. And you have got the modifier, that is, it might be L1 plus L4 if it is involving terminal ileum and upper GI. It may be L2 plus L4 if it is colon and upper GI. It may be L3 and L4. It may be ileocolonic and upper GI. Now, if all this disease is associated with perianal disease, you have to add the suffix small p to this behavior. That is non-stricturing, non-penetrating perianal disease P. Stricturing perianal, penetrating perianal, and so on. So you see this patient, it is A2, B2, L2, and if it is A2, it is 17 to 40 years. B2 is stricturing disease. L2 is colonic. So the option will be A, stricturing, 25 years, and colonic. That is A2, B2, and L2. This was the question asked. Also, never forget about the Montreal classification for ulcerative colitis. The parameters mainly are E and S. E is the extent, the maximal endoscopic extent during follow-up, E1, E2, E3. E1 is ulcerative proctitis, which is limited to the rectum. E2 is left-sided, limited to the colon, distal to the splenic flexure. E3 is extensive ulcerative colitis, the disease proximal to the splenic flexure, and disease severity S0, S0, S1, S2, S3. S0 is clinical remission with no symptoms. S1 is mild passage of 4 or fewer blood stools per day, with or without blood, absence of any systemic illness, normal inflammatory markers. This is nothing but the true love and Witz criteria, mild disease. S1. S2 is moderate true loves and Witz criteria, anywhere between 4 to 6, minimal signs of systemic toxicity. S3 is severe disease, true love Witz criteria, passage of at least 6 bloody stools daily, pulse rate of at least 90 beats per minute, temperature of at least 37.5 degrees Celsius, hemoglobin of less than 10.5 gram per ml, and ESR of at least 30 mm per hour. So this forms the Montreal classification of ulcerative colitis. Now, coming to the next question, which of the following regarding management of a through and through gunshot wound to the sigmoid colon is true? How do you manage a gunshot injury, that is a penetrating gunshot injury to the sigmoid colon? This question is typically taken from Shackelford. What Shackelford says is that in all this penetrating gunshot injury, if there is a small area, partial thickness disruption, then you can do a primary repair. But larger areas, it is always best resected to avoid the complications of delayed full thickness necrosis. So if you repair it primarily, you have to debride the non-viable edges, and single lower closure with Lambert sutures will be enough. But again, through and through perforations, generally you have to excise the contuve segment between the wounds and convert it into single perforation, and then do an anastomosis. Formal resection and re-anastomosis is generally wise for destructive injuries, especially if there is a question about the vascular supply. So, what is the conclusion of this paragraph is that if there is small areas of if there is small areas of partial thickness, then you can go in for primary repair. If there are large areas, then try to resect it. If there is a through and through perforation, then excise and anastomose. Excise and anastomose. Always primary repair it, debride it, and do it single layer with Lambert sutures. Buttress repair or anastomosis with momentum. Buttress, that is repairing or buttressing the anastomosis with momentum is not recommended, although it is commonly done. So going to the question, which of the following regarding the management of a through and through gunshot wound to the sigmoid colon is true? You have to go in for a resection of sigmoid colon, and end-to-end anastomosis of the colon is the correct option. Correct option, yes. Now, coming to the next question, which of the following is not true for a patient who is diagnosed with ulcerative colitis found to have jaundice? On investigations, his alkaline phosphatase and bilirubin is altered or elevated. Now, this is a patient who is finding ulcerative colitis. Now, remember, my dear friends, if it is ulcerative colitis and the patient is having jaundice, the first thing you have to have in your mind is primary sclerosing cholangitis, where the patient will be jaundice due to various strictures due to primary sclerosing cholangitis. The patient will have derangement of alkaline phosphatase, and because of the cholangitis, even there will be alteration in liver enzymes. Now, what are the options? Occurs in 5 to 8% of the patients with ulcerative colitis. Okay. Genetics plays an important role in predicting these patients who will develop jaundice. Option C, typically these patients have Poisson disease. Option D, the risk for colon cancer is increased up to 50 times in this patient. Now, coming to answer is D, because coming to the primary sclerosing cholangitis in ulcerative colitis, it occurs in 5 to 8 percentages. And most of these patients are younger patients, that is less than 40 years, and mostly they are men. Genetics likely play a role in patients with ulcerative colitis. So if you take, it is HLA-B8 or HLA-DR3 haplotypes, which are 10 times more likely to develop as primary sclerosing colitis. One interesting finding I'll tell you in primary sclerosing colitis with PSC with ulcerative colitis, the disease as such, the disease process will be a quiescent course type of picture, but the risk for cancer is around 5 times greater than that of the patients who are having ulcerative colitis alone. So if any patient has primary sclerosing cholangitis along with ulcerative colitis, then remember that the risk for colonic malignancy is around 5 times more than a patient who has only ulcerative colitis. That is what I've written in red. The PSC with the UC cancer is 5 times. So increased risk for colorectal neoplasia. Also, these tumors, if you see, are more likely to arise proximal to the splenic fixture, and patients due to the primary sclerosing cholangitis, they'll have symptoms of obstructive jaundice and cholangitis and abdominal pain that will lead to cirrhosis, and ultimately it will become fatal unless you do liver transplantation. Primary sclerosing cholangitis will not find a role, and doing colectomy alone has no effect on the course of primary sclerosing cholangitis. This might be a future potential target for another MCQ. You do a colectomy, the primary sclerosing cholangitis is going to resolve, is what one of the future option would be in your exam. And remember that colectomy has no effect on the course of primary sclerosing cholangitis. So any patient with PSC with ulcerative colitis, there is always an increased risk for colorectal neoplasia, and also there is a risk for cirrhosis, liver failure, and transplant, and unless you do liver transplantation. Apart from this extraintestinal manifestations, in ulcerative colitis, the arthritis, particularly the knees, ankles, hips, and shoulders, the large joint arthritis, peripheral arthritis, tips are typically in 20% of the patients, and also skin manifestations, erythema nodosum, 10 to 15% of the patients occurs in conjunction with peripheral arthropathy, and ankylosing spondylitis associated with HLA-B27, 3 to 5% of the patients. These all might improve or completely resolve after colectomy. And sometimes even pyoderma gangrenosum occurs in the pretibial region as an erythematous plaque that progress into ulcerated painful wound might also occur. So here, coming to the options, occurs in 5 to 8% of the patients with ulcerative colitis. Yes, it is 5 to 8%. Genetics play an important role. We already saw the genetics being HLA-B8, HLA-DR3, and typically these patients will have a Poison disease. I said that is the interesting point. Typically, PSC with UC will have a Poison disease course. But again, if both are present, the risk for colorectal neoplasia is increased, and it is not increased 50 times, it is increased 5 times, and that is the false statement regarding this patient. Now, some miscellaneous topics here and there were also asked. So, which of the following is the next clinical test to be done in this 45-year-old patient, and contents are reducible on lying prone? So, this is a typical picture showing a superior lumbar triangle hernia. So, what are these lumbar hernias? These hernias are the one which occur through a parietal wall defect in the lumbar region, whose boundaries are the 12th rib superiorly. You can see in the typical boundaries of the superior lumbar triangle. What you actually call it as a superior lumbar triangle of Greinfeld, inferior lumbar triangle of Petit, and superior lumbar triangle of Petit, Greinfeld. The boundaries are 12th rib superiorly, the iliac crest inferiorly, and the rectus spinae muscle medially, and the posterior border of the external abdominal muscle oblique laterally. So now the superior triangle, you can see this is the inverted triangle. 12th rib is superiorly, internal oblique is anterolaterally, and the quadratus lumborum, which has been marked, is posteromedially, and the latissimus dorsi forms the, you can see in the right, and the aponeurosis of the transversalis fascia forms the roof and the floor here. The latissimus dorsi in this picture forms the roof, and the transversalis fascia forms the floor. And these are the boundaries of lumbar hernia. What the patient will have is the patient will have pain, and depending on the contents, the pain can travel down the distribution of the sciatic nerve or refer to the anti-abdomen. So all these patients will have GI complaints such as nausea, vomiting, or bloating. Mass is palpated in the lumbar region. It is often soft, fluctuates in size, and the mass may protrude with coughing or bearing down, and even produce bowel sounds on auscultation based on the contents of the hernia. Now, so the diagnosis can be made upon physical examination only, because lumbar hernias might be the diagnosis can be made upon physical examination in the majority, but if it is less than 5 centimeter of the diameter, then you have a defect which is very small and it will not be that apparent. Then the preferred diagnostic modality in patients will be CT. CT scan is the preferred diagnostic modality in patients who present with signs and symptoms concerning for a lumbar hernia. It can provide useful information about the size of the facial defect and allow the assessment of the hernial sac and regional anatomical relationships and so on. So the next step, what they're asked is how to confirm this. The clinical test, if you palpate it, you'll have an expansile cough impulse and it will be reducible is what they have said. And you can detect the relation with 12th rib. So USG detection of lumbar hernia is not that specific. CT is the investigation of choice. And so option will be B, demonstrating the expansile cough impulse rules out hernia, and the contents are reducible there. And if it is there in relation with 12th rib, it is along the superior lumbar triangle where the 12th rib forms the superior boundary of the border of the superior lumbar triangle, and the inferior border being the iliac crest. And so that will be the option, that will be the answer. Coming to coming to the next question. So which of the following is false regarding prophylactic colectomy done for FAP? So they had asked the statements which was given were that it alleviates the patient anxiety, it removes the need of yearly colonoscopic follow-through, no need for rectal cancer surveillance, should not have done prophylactic colectomy in the first instance. So, uh, what do you do for a FAP? So you need to remember that in fact, the colorectal cancer risk is around 100 percentage, where it's only 80% colorectal cancer risk in attenuated FAP. And the most common cause of death in classical FAP is colorectal cancer. The median age of colorectal cancer is 39 years, whereas it is 58 years in attenuated FAP. How do you screen these patients? You screen by starting proctosigmoidoscopy at the age of 12 to 15 years. If there are no polyps, repeat every 1 to 2 years or earlier if the symptoms develop. If polyps are seen, a full colonoscopy is warranted until age of 35 years. And if there are no polyps until 35 years, then you can do it every 3 to 5 years thereafter. Genetic diagnosed FAP patient and the primary relatives of these persons with clinical diagnosis should always undergo this type of screening. Apart from this, the colorectal we have seen start from 12 to 15 years and 1 to 2 years interval. Apart from that, you have to do a side viewing scopy in all those patients from age 25 to 30 years. And you have to have a USG or palpation of the neck by to rule out thyroid cancers 25 to 30 years. Um, so based on this condition, when you have to do surgeries, so what are the options you have got for surgeries? So you can do a proctocolectomy, be it stapled or ansuin, and do an iliopouch channel anastomosis. So what are the indications of proctocolectomy? If the patient is having a profuse or a severe familial phenotype, harboring more than 1,000 synchronous adenomas and adenomas, then you go in for a total proctocolectomy with ileal pouch channel adenoma, ileal pouch channel anastomosis. So in all these patients, the patient will be having a large polyp burden in the rectum, that is more than 20 synchronous adenomatous polyps in the rectum, and the size of the polyp will be more than 3 centimeter large adenomatous polyps of the rectum. The adenoma will be present with high grade dysplasia and sometimes even rectal cancer. So with 1,000 polyps in the colon and rectal polyps more than 20 in number or more than 3 centimeter in size, or those presenting with high grade dysplasia, or those presenting with rectal cancer, then it is an indication for absolute indication to do a proctocolectomy with ileal pouch channel anastomosis. But if all these are absent, then you can go in for subtotal colectomy with ileorectal anastomosis. If there are less than 20 polyps in the rectum, less than 3 centimeter polyps, no rectal cancer, no adenoma, you can also so in that those patients you can do a subtotal colectomy with ileorectal anastomosis. You can always do a proctocolectomy with end ileostomy if the if the patient has very low rectal cancer and sphincter preservation is not possible for such patients, then you have got the option of proctocolectomy with end ileostomy. But this is what I was talking. If the patient has got a few rectal polyp less than 20, family history of mild phenotype, attenuated familial adenomatous polyp, young females who desire to become pregnant after genetic counseling, then you have the option of offering subtotal colectomy with ileorectal anastomosis. And the risk of metaclonus rectal cancer is in the order of 30%. So, uh, IRA is contraindicated in severely diseased rectum. We saw adenomas more than 3 centimeter in diameter, those with severe dysplasia, cancer, sphincter dysfunction, or a rectum containing more than 20 rectal adenomas, or in the presence of colon cancer. The good results will be obtained in attenuated FAP, MAP, and mild FAP. This is important point in those patients who agreed to undergo close follow-up or compliant enough to have his rectum under surveillance in the upcoming months to come after the surgery. Yeah. But if the patient is not compliant enough to undergo a close follow-up of his rectum, then this procedure is contraindicated. Contraindicated. So options here, it alleviates patient anxiety. Yes, removes the need of yearly colonoscopic follow-through. If you're going to do a total colectomy prophylactic, there's no need for yearly colonoscopic follow-through. Yes, correct. And no need for rectal cancer surveillance. is a wrong statement. Also, should have not done prophylactic colectomy in the first instance. That the details were not that much. The option was not that much correct here because prophylactic colectomy is almost always indicated if at all polyps are present. And because the risk of colorectal cancer is around 100%. And so I would go for the option C here. No need for rectal cancer surveillance is a wrong statement because you are doing only a prophylactic colectomy and leaving the rectum is a bad option. But again, it depends upon the nature of the rectum and the disease of the rectum, how we saw. But always, if you have left the rectum behind, then you have to have a screening protocol for rectal cancer for this patient. And a strict compliant patient would be the ideal candidate to have his colon removed and rectum preserved and have a regular follow-up of his rectum. Now, coming to the next question, 17 years old gentleman underwent EVAR postoperatively, developed shock with organ failure. On palpation, the resident found abdomen to be tense. Best measurement of the condition is by A. Intravesical pressure, B. Abdomen girth monitoring, C. Gastric pressure with ventilation status monitoring, D. CT angiography. So here is a patient who underwent endovascular repair of abdominal and aortic aneurysm repair. Post-operatively, he dealt shock with organ failure and the abdomen is tense. The diagnosis is abdominal compartment syndrome. So where do you describe ACS? ACS, normally the intra-abdominal aortic pressure in a healthy individual is less than 8 mm mercury. So if you have the patient any pressure above this, it is intra-abdominal hypertension. If intra-abdominal hypertension, that is pressure greater than or equal to 12 millimeter mercury, along with new organ dysfunction or organ failure, and improvement after abdominal decompression is what is called as abdominal compartment syndrome. Here, the patient will have acute increase in IAP, that is intra-abdominal pressure more than 12, and associated organ dysfunction with hypotension, oliguria, respiratory insufficiency, and so on. So there are primary causes, secondary causes. Primary causes as a result of intra-abdominal pathology, that is blunt or penetrating abdominal trauma, hemorrhage, abdominal aortic aneurysm rupture, and surgery, post-surgery, intestinal obstruction, retroperitoneal causes, and all that. How will the patient present? So here the patient, all the clinical manifestation, you have to remember that the abdomen is getting severely distended and there is increased intra-abdominal pressure on the pulmonary, cardiovascular, and renal systems. Most patients, tense abdominal distension and elevated IAP, they'll be having difficulty ventilating because elevated airway pressures and because of tense abdomen, there is going to be compression on the IVC. If there is compression on IVC, there is going to be decreased venous return and the cardiac output will be low and the renal perfusion will be less, the decreased urine output, all the visceral organs will have hypoperfusion, progressive acidosis, and all these parameters will resolve once the abdomen pressure is going to get resolved or you're going to decompress the abdomen now. And so to have the diagnosis, it's a clinical syndrome in all these high-risk patients with severe abdomen distension, elevated intra-abdominal pressure, organ dysfunction, with difficult ventilation, hypoperfusion, low urine output. I told the mechanism because of compression of IVC. And IAP can be measured using direct, indirect methods. Most common measurement of IAP is by connecting the transurethral Foley's catheter to a pressure transducer. We do it all the time in the ward. And elevations in IAP can be classified as grade 1, 2, 3, 4. And 1 is 10 to 15 centimeter water, 2 is 15 to 25, 3 is 25 to 35, grade 4 is more than 35. Yeah. And as the IAP increases to grades 2, 3, and 4, the degree of organ dysfunction progressively worsens. Most patients with grade 3 and all patients with grade 4 require abdominal decompression. And this is the treatment of choice for abdominal compartment syndrome. So the option based here, it will be intravesicular pressure monitoring. The measurement would be the best to measure this condition, namely the abdominal compartment syndrome. So I left one question previously, which I said I'll discuss later. The reason I wanted to quote here is that I didn't get exact reference, although I'm searching for it. This question, other, I'll add to the PPT and post to you. No worries, but I know the answer. I am not getting it in your standard textbooks. I have collections of some journals for this, and I'll add to this and post to you. Now, which of the following regarding the principles of fundoplication is not true? Doors fundoplication, fewer side effects. Toupee has more gas bloat syndrome. Nissen's is the most durable repair. Partial gastrectomy with Roux-en-Y GJ for recurrent reflex. Now, come to the option D. Partial gastrectomy with Roux-en-Y GJ for recurrent reflex, yes. If all your fundoplication is going to fail, then better to do a gastrectomy and do Roux-en-Y because the basis of Roux-en-Y is you try to prevent the reflex. So for recurrent reflex, Roux-en-Y is the best, and this is described in Shackelford. I'll quote the reference and post it to you in the PPT. So that is a true option. Nissen's is the most durable repair. That is also a true option because with Nissen's 360-degree fundoplication, the post-operative recurrence is around only 1% because you're going to have a complete wrap. And Doors fundoplication, it's one of the anterior fundoplications, got a fewer side effects. So the answer is Toupee has got more gas bloat syndrome. No, it is the other way around. It is in essence, Toupee has got decreased gas bloat syndrome. This reference I'm not getting it from anywhere. I'll try to search the journal and post it to you. But the answer is Toupee has got more gas bloat. And all the other questions I've given the explanations. I hope we have finished all the questions which was discussed in the previous years, around 17 in number. uh, i uh, i uh, I ask you people to go through all the notes and questions which we have discussed in the previous sessions. I think that alone forms the basis for you people to revise and to get a good concepts which would be useful to crack all those questions and to have uh, your Bailey and Sabiston thoroughly revised and with some important topics like Shackelford to some point might be helpful. See you in the next session and thank you. Uh, shall we stop?
Yes, sir. Thank you, sir.